there are different functional or better physiological, actually, imaging modalities, because they don't actually measure function, they measure physiology, are used in GYN imaging, not just in endometrial cancers. You can have dynamic contrast-enhanced or perfusion ultrasound, CT, MRI, diffusion-weighted MRI, MR spectroscopy, as well as PET-CT. Since this is endometrial cancer and there's only 10 minutes, I'm going to concentrate on the role of diffusion-weighted MRI and PET-CT a little bit on evaluation of patients with endometrial cancer. Just one or two slides about diffusion, the principles of diffusion. Essentially what diffusion-weighted imaging measures without any use of intravenous contrast medium is the movement of water molecules in tissue, not just in cancer, but in any tissue. So less packed the cells are in a tissue, more water diffusion there is, so less restricted diffusion, the other way around. So tumors or any very packed cell tissue have restricted diffusion. So it's not tumor-specific, but the diffusion is restricted in tumors. Also can give you information about capillary perfusion or inherent perfusion of a tissue, which is actually a very important feature which we are trying to use more and more when we design at least the imaging studies, because you can evaluate the inherent tissue perfusion without giving any contrast. And why is that? Because not only you have this movement into the extracellular intracellular space, but also you have this movement into the capillaries. And now with the improvement on modeling and physics, you can actually measure this diffusion or rather perfusion in the capillaries very, very well. So let's just show you examples of how by combining morphology, which comes for free beautifully with the MRI, well, not quite for free, but without extra efforts in terms of post-processing and function or physiology, you can actually help or add in various scenarios. For example, in lesion characterization, in staging and treatment selection and planning, treatment follow-up and detection of tumor recurrence, as well as in the prediction of treatment response and finally outcome. So I'll just start with this case. What I mean with the apparent diffusion coefficient, it's actually the metric for the quantitative variable for diffusion-weighted images. So these are diffusion-weighted images which are qualitative, so you just eyeball them. But this is the map here, the apparent diffusion coefficient map is quantitative. So you can actually draw an ROI in each part of the tumor here and actually get a value which tells you how cell dense the tumor is. So we know now from our group publication, other groups, that grade 3 endometrial cancers have lower ADC value, so they are more cellular, and that's no surprise on that, than grade 1 or 2 endometrial cancers. However, there's no data in type 2 endometrial cancers. This is a very interesting case which at office biopsy showed a grade 2 endometrial carcinoma. When you look at the ADC map here, you can see there is one area of tumor which is actually very dark, so very restricted diffusion, another area of the tumor here which is less dark, so there is more free water movement. And this is just a pretty picture combining both just to show the anatomy and the overlying function. At pathology, there was a mixed tumor having grade 2 endometrioid carcinoma and a serous papillary component, which corresponding exactly to this area of very restricted diffusion on ADC map. So again, you can see how you can combine both to better characterize the tumors. This is another case at my previous institution where I worked, and it was a patient, a premenopausal patient, which came with bleeding. So it was a polyp at hysteroscopy, which was subsequently removed after this MRI. The MRI was done because she wanted to preserve the fertility. And what we saw this other lesion, which probably to an experienced eye, it's easy to say that this is completely different from the polyp, but not as easy for an unexperienced eye. But you can see here how different those tissues are, with the polyp here being less dark and the cervical cancer, as it is here, being a really restricted diffusion, bright on the diffusion-weighted images. And indeed, this patient went for trachelectomy for a cervical cancer rather than atypical hyperplasia on a polyp for endometrial cancer or query endometrial cancer. Again, very useful to plan this preoperatively. When it comes to stage of endometrial cancer, I know in the US we don't use the MR as much to stage endometrial cancer. We use more CT, although we're kind of going that way now, even our institution. In most European centers, you'd use MRI to accurately evaluate depth of myometrial invasion, because not every patient goes to lymphadenectomy or even a sentinel node. So this is used to actually direct patient to a full lymph node dissection. It also has another scenario which is used very, very widely and could potentially really help in that on preserving fertility in this patient. So this is a patient with endometrial cancer here. This is a junctional zone, the inner myometrium. This is the outer myometrium. And on those images alone, it can be very difficult on the anatomical images only to actually say there is myometrial invasion, yes or no. There's certainly no deep myometrial invasion, but not sure if it's superficial or none. On diffusion weight images here, easy, a very good tumor to adjacent myometrium contrast in this case without any intravenous contrast agent, just inherent tissue contrast. And you can see here there's a really irregular tumor to myometrium interface, and this is certainly superficial myometrial invasion. That was the case at the final pathology. This patient had hysterectomy. You can go on and produce this panel fairly easy, and we actually produce this routinely in the cases we do here, with tissue-weighted images here, with both sagittal and oblique plane perpendicular to the tumor for better assessment of both deep myometrial invasion and parametrial invasion in the low uterine segment tumors. You can see after contrast here, the tumor to myometrium contrast is better. Definitely on diffusion-weighted images, it's also much better, and also on the ADC maps. Don't forget, this only takes 2 minutes to acquire, and press a button to generate those maps, and no need to give an injection of intravenous contrast. Just to show you that diffusion can also pick up very subtle abnormalities, not just big tumors invading deep or superficial to the myometrium. This is the case of a serous papillary tumor. Again, the sagittal image here with the uterus, the bladder just for the orientation, and the pubic bone here. Nice post-contrast images showing that this is actually probably 50% of the myometrium. At pathology, was 55% of the myometrium. It's not always easy to actually get it accurately, but more to the point, as you scroll through diffusion-weighted images, there is a very bright focus on the left adnexa. This is a postmenopausal patient, kind of difficult to point it on the anatomical images where it is, because the ovary is not even seen here, but along the left ovary, and you can fuse the images for better anatomy, and indeed was an 8 millimeter deposit on the surface of the left ovary. So you can actually go to very, very small sizes when it comes to resolution of diffusion-weighted images combined with the anatomical images. You can combine all, and this is the study I did in collaboration with McGill University in Montreal. When we had a fellow that worked on both sides, and we looked at combining everything. So we looked at doing the volume, not just on the T2-weighted images and not just the uterus volume, but also tumor volume, but also on the 3D diffusion-weighted images. And again, those maps are extracted, the 3D volumes are created, and this is the pathology on this patient, the gross pathology. And what we found, which was actually very interesting and important probably in fertility preservation group, is that a tumor to uterus volume ratio of 25% excluded presence of deep myometrial invasion. So if that was the ratio under 25%, no patient had myometrial invasion. This was based on over 70 patients. When we did the histogram analysis of the ADC values, there was a significant difference between grade 1 and 3 tumors, so it's telling us about tumor aggressivity. And also, the tumor volume histogram ADC value actually could predict presence of lymphovascular invasion in the study population. So I just wanted to give you a feel how you can combine all the great resolution, anatomical resolution of MRI with physiology and function to actually start even predicting certain things like lymphovascular invasion and also depth of myometrial invasion. Just a slide or two in detection of tumor recurrence. Yes, of course, you can see areas of recurrence better on diffusion-weighted images, although it's limited to the area you're imaging on MRI. And MRI takes a long time and it's expensive. And this is a recurrence on a patient with serous papillary endometrial cancer. You can see it's along the sigmoid serosa, not the sigmoid cancer. You could say on this PET would be a probably sigmoid cancer if you just saw those images, because there's not much anatomy on this unenhanced CT. However, PET adds a tremendous value when looking at disease extents on those patients, because what was missed on this MRI, because it wasn't covered, it was this small serosal deposit along the liver surface. Again, very, very important, and PET is very useful in detection of these areas of recurrent disease with a very good sensitivity and specificity. Again, an example of combining metabolism and anatomy in a very meaningful way. What we also looked at and published recently is combining the MR and PET information in patients undergoing pelvic exenteration. This was a mixture of endometrial, ovarian, and cervical cancer patient, but this is an example of endometrial cancer patient with recurrence. And this is MR and PET acquired on separate days, and they were fused together because we didn't have an MR PET machine, which we're going to have in the second quarter of next year, hopefully. But nevertheless, it shows you that on MRI here there is tumor going around. Where does it end? Does it actually goes close to the pubic bone? These patients have had radiotherapy before, so it's not actually that easy on anatomical imaging to make a distinction. But then here you combine the information of PET, so the metabolism with the anatomy, and you can see the extent of this tumor. And this is really helpful in planning pelvic exenteration. We discuss those cases on a monthly basis on our pelvic reconstruction DMT. Moreover, the parameters that were derived from both diffusion-weighted images and PET were significant in predicting outcome on those patients. So are there unresolved problems? Yes, many, as with everything. The MRI is actually slightly more difficult to standardize compared to the CT. So yes, there is a problem with different vendors, different protocols, and different analysis software, and there is a whole MR community trying to work to sort them out. There is a cost associated, not just with the acquisition, but also image analysis. And if we think of the new tracers with the event of the MR PET, it's really exciting because we can actually, with certain tracer, we can interrogate hypoxia, apoptosis, proliferation, and combine that with a wonderful and superb soft tissue resolution of the MRI. However, for the new tracer, it comes at a cost because obviously some of them are not FDA approved. Again, the role of MR PET is to be discovered, but I think it will actually tremendously add to the either MR or PET alone. And of course, some of this data I showed you, some of these images I showed you are already available to you, but some or more of a volumetric one are not, so we have to find a way to actually press the button with those things and just make the results available to you before or as you see the patient. And lastly, but not the least important, is a better understanding of tumor biology and microenvironment and correlation with the genomic data. And I actually added that after the talk that Dr. Liu gave because I thought it was really a fascinating talk. And I thought, okay, we can even do texture on MRI and predict who is going to respond to progestin or not. And I should stop giving ideas because Dr. Abrustum will be upset. So thank you very much for your attention.